Started and introduce our speakers and the topic today, and then pass the mic over. We have 4 presenters, which is very exciting. The first presenter, who's usually on the other end of the mic introducing the speakers, is Shanlea Gordon. Shanlea is the Senior Research Manager of the BC Children's Hospital Research Institute's Clinical Research Support Unit. She's also the Research Manager for the FIR program at BC Women's Hospital, so we're lucky to have her connected to WHRI as well. We have Henry Okpaladigbo. Sorry, Digbo. Henry, I'm terrible. You are from the BC Children's Hospital Research Institute's Clinical Research Support Unit as well. We have Heather Noga, who is the Research Manager for the Endometriosis and Pelvic Pain Lab, also at BC Women's Hospital and the WHRI. And we have Erin Fernie, who is a member of the Patient Advisory Board for the Endometriosis and Pelvic Pain Group, who I think takes the cake as far as the best background of all of us. So we're super excited to hear from these 4 today, who are presenting on a new resource for C&W research folks on patient partner onboarding. So I'll pass the mic over to you.
Thanks so much, Nicole, for that warm welcome. So like Nicole mentioned, today we're going to be presenting some new guidance for research teams engaging patient partners in research at Children's and Women's. We'd like to start by acknowledging that our work takes place on the traditional, ancestral, unceded, and occupied territories of the Coast Salish people, specifically the Musqueam, Squamish, and Tsleil-Waututh nations. And we're grateful for the opportunity to live, work, and learn on these sacred lands. It is important to acknowledge the painful history of colonization, racism, and marginalization that Indigenous and First Nations people have endured and continue to face today. It's important to take a moment for us to honor the strength and resilience of the Indigenous communities in the face of systemic injustice and inequality, and recognize our roles at the research institutes in reconciliation, including decolonizing research and research practices. So today, what we're going to present is first give a little bit of context and background into why we did this work, why it's important to appropriately onboard and train patient partners in a research context, actually review the content of the guidance tool with you all, and then going to turn things over to Henry, who's going to provide a demo of this really exciting new tool, the Research Patient Partner Onboarding Sorting Tool, and then pass things over to Heather and Erin, who are going to describe a little bit about their patient-oriented research and how this work can be operationalized at Children's and Women's. So for the purposes of this presentation, when we're referring to a patient partner, what we mean is a patient or family member that supports, contributes to, consults on, or co-designs research projects or programs with research study teams. We really like the term patient partner, specifically the partner piece, which is endorsed by the Institute for Patient and Family-Centered Care, as it really denotes meaningful engagement and true collaboration. However, something that I've learned in my work is that it's also really important to have discussions with the patients that you're engaging and ask them what they would like their job title to be and how they would like their role described, which could be a number of different things like peer research associate or peer research consultant, the name of your project or committee member, co-investigator, a number of different things might be appropriate. Patient and family engagement in clinical research is becoming more and more commonplace, which is really amazing. It can improve the quality, appropriateness, and relevance of the research that you're doing. Engaging patients as partners in research has also been demonstrated to lead to better health outcomes for patients and ultimately improved healthcare systems and decreased healthcare costs. So it's really important. Additionally, it's also becoming increasingly required by funding agencies like CIHR and research oversight committees at Children's and Women's Hospitals. So our site is seeing an increase of investigators and research teams looking to meaningfully engage patient partners in their research projects and programs. On this slide, I have the IAP2 spectrum of public participation that's often adapted in patient-oriented research, just to describe the different ways that you might engage a patient partner in a research setting. So going from the left-hand side from inform over to empower on the right-hand side, the level of engagement in the research project increases. And over on the right here, empower, which we also sometimes call co-design in a research context. It's really like the patient partner is a co-investigator or co-principal investigator, and what we'll study is what you want to study, and what you want implemented is what we're going to implement, and do this really collaboratively and together. This isn't always possible or feasible, which is why there's different levels, but it's definitely a level of engagement that we strive for in a research context. So the role of a patient partner on a research team, patient partners can take on a number of various tasks. It really depends on the project and scope of your work. So patient partners at Children's and Women's might be supporting things like co-writing study protocols or supporting knowledge translation, like conference presentations or community presentations. They could be reviewing data and interpreting end of study findings. It really just depends on the project. So there is a ton of information and resources already out there regarding why it's critical to engage patients as partners in research, the importance, the benefits, and how to do so in a meaningful, patient-centered, supportive, trauma-informed way, which is really great. And there's, like, as you can see, just a ton of resources here. So we know it's important. We want to engage patient partners in research. We have guidance to do so in a good way. But as a member of a research team at Children's and Women's, so with BCCHR or the WHRI, how do we recruit a patient partner and onboard them? Like, do they need training? What are the requirements for patient partners at Children's and Women's? And this was a genuine question that I had myself back in 2021. I've had the privilege to just one second. Sorry. There we go. I've had the privilege to work with patient partners. Did you hear that? No, that's okay. I've had the privilege to work with patient partners at Children's and Women's for several years now. But these folks were already members of the research team when I'd come on and joined. And it wasn't until 2021 that I was looking to recruit and onboard new patient partners myself. So the tasks that patient partners support, as we've already described, can vary and might involve access to sensitive patient information or unpublished data. And that's part of the reason why it's so challenging to try and determine what are the requirements for onboarding and training patient partners. Additionally, there's no regulatory body that oversees patient engagement and research or QI/QA. And patient partners are not staff, they're not volunteers, they're not trainees. So a number of groups at this site have had difficulty in terms of how do we classify patient partners to ensure that they're getting the best support and training. So we decided back in January 2022, we don't have the answers to these questions, and we need to have answers to these questions. So we're going to get clear answers and decided that we're going to tackle developing some onboarding and training guidance for patient partners at Children's and Women's. Where I started with all of this was collating and summarizing some of those existing resources that you saw on an earlier slide and identifying what we do know and what we don't know. And I was thinking about timelines, and I think it was in 2022, I reached out to Nicole Presley, who introduced me earlier, who really should be co-presenting this presentation with us today. Nicole's the manager of research and knowledge translation at the WHRI. And Nicole and I came together and made the decision that this should be a BCCHR WHRI collaboration and put out guidance for all research teams at the site. We also reached out to Linda Warner, who's leading the BC Children's Hospital Health Bridge and has been doing patient-oriented research at BC Children's Hospital for many years. And Nicole and I started reaching out to a number of different stakeholders to help inform this work and help get us some more clear answers to these questions, to this knowledge gap that we have. We also brought together an amazing working group with a number of research staff who are already engaging patient partners in research at the site, including Heather Noga, who's going to be speaking soon, some of whom have decades of experience doing this work, like Heather and others who are more new to patient-oriented research. And the working group really informed and critically reviewed and gave a ton of important feedback and guidance to help build this out further. So without further ado, we'd like to spend some time reviewing the content for the patient partner onboarding for research guidance document, and just wanted to flag here the working group membership. So Heather, like I already mentioned, was a part of the working group, but also Gordon and Mary and Beth and Emma and Britt were all very instrumental in making this happen. I've also included a website at the bottom of this slide here, and I think Jess might be dropping it in the chat for us, where folks can go and access this document where they will live. It's on the hub for those folks calling in from BCCHR side, and it's going to be up on the WHRI soon. And we also have a link to a share drive that I think Jess is sharing as well. Also wanted to acknowledge, like I mentioned, putting together this guidance really required a ton of collaboration and expertise from a number of individuals and experts who are all listed here. It took a ton of meetings and emails and back and forth collaboration. So thank you to everybody involved. So starting off, getting into the actual meat and potatoes of the guidance document, we have a number of resources, like we mentioned, that already existed. So Nicole, Linda, and I compiled them all and put them in one place for everyone to access. So we have different sections in terms of like getting started. So these are sort of more foundational, where to begin engaging patient partners in research documents and information. And then we also have sections on language and compensation and training. We also, in Table 2, highlighted the ways to overcome some common challenges to engaging patient partners in research, including funding and resources, inequitable power dynamics, which is, a part of the nature of research. Even research participants, we know that there are power dynamics, so there are also power dynamics that need to be taken into consideration when engaging patient partners. And then also tokenism, so ensuring that the engagement is actually meaningful and collaborative, and not just ticking a box. So once you've read these resources, you've dove into what already exists, and then we're shifting now into how to identify a patient partner. So we know we want to work with a patient partner. How do we find these folks? And two questions that we've had at the Research Institute time and time again is, one being, is it appropriate for the PI to approach their patient about a patient partner opportunity? Or is that like inappropriate, like if they were a study participant? And two, can we disclose the patient partner's identity? So contrary to recruiting patients as participants in research, it is totally appropriate for an investigator to approach a patient within their circle of care and invite them to join their team as a patient partner. We've also included appendices to accompany this guidance document. And on the right here, you can see we have a template script for how an investigator might consider inviting one of their patients to join their study team as a patient partner. And then circling back to the confidentiality piece, it's also just important to note that patient partners do differ from study participants also in terms of confidentiality. So patient partner confidentiality doesn't necessarily fall under the same umbrella as research participant rights to confidentiality. As a patient partner is hopefully an embedded member of the research team, patient partners should expect that their name and role with the study team might be shared, similar in a way that a co-investigator might have their name and their role shared. Like, for example, we introduced Erin today as a patient partner with the Endometriosis lab, and that would be totally inappropriate if Erin were a study participant and I were speaking about the study, but is appropriate given she's a patient partner. It's also important that when you're first connecting with patient partners about a patient partner opportunity, that this piece about confidentiality is made clear, that as a part of the role with this research team, you would expect like your job title to be associated with you. In addition to inviting your own patients to join your study team, we've also included a number of groups in the guidance document who have already established networks of patients who have indicated previously an interest in being engaged as a patient partner. So on site, we have the BC Children's Hospital Mental Health Registry Partnership that Gordon is helping lead at BC Children's Hospital. There's also the BC Support Unit, Reach BC, Patient Voices Network, the Children and Women's Patient Experience Office led by Mary McKillop. And then if you're looking for elder engagement, you can also contact the Indigenous Health Team at Children's and Women's. So onboarding recommendations. So onboarding processes are largely dependent upon the role of the patient partner, which I'm feeling like a broken record. It changes based on the project, right? So how do we onboard a patient partner in a research setting at Children's and Women's? We have developed some onboarding tasks that are recommended for most or all patient partners with the WHRI and BCCHR that we're going to run through together now. So the first thing that we recommend is having a patient partner sign a pledge or a waiver of confidentiality. This is just noting that the information that they review or they're privy to in a team meeting, etc., is confidential. So it could be sensitive patient information, for example. It could be unpublished study findings, just making sure that it stays within the study team and it's private. We do have a template on the right-hand side, which is a part of our appendices document for folks looking to implement this with their patient partner groups. The second piece is a criminal record check. So the issue of whether a patient partner should complete a criminal record check was honestly a bit challenging to sort out. Nicole and I were beating our heads against the wall for a long time about this, going back and forth with lots of different stakeholders. Everyone in this space wants to ensure that patient engagement in research remains low barrier, and recognizing that a criminal record check for some people or all people is a barrier. Also, as this guidance is children's and women's wide, so applicable to both the women's health and children's health research, we also think about some circumstances like, for example, women's health research and forensics research that maybe by virtue of being a patient partner in forensics, you need to have a criminal record. So how does that work? There were some complexities there. What has been decided is ultimately a criminal record check is a risk management tool and something that all members of a research team go through as part of keeping everyone safe. So the following criteria that you see on the slide is what was ultimately agreed upon. So if you're working with a patient partner that does not have contact with children or vulnerable adults, and they do not regularly work at Children's and Women's on-site at the Oak Street campus, they don't need a criminal record check. So thinking about patient partners who are on advisory committees or participating in Zoom meetings, mostly reviewing like patient-facing documents at home, for example, or over email, these folks do not need a criminal record check. It's also important for me to just note that patient partners can still come on site. Like if you're coming on site for a one-off team meeting or orientation, HR classifies you as a visitor, so you don't need a criminal record check. It's just if you're working regularly on site and or if you have contact with children or vulnerable adults that a criminal record check is recommended. So then the other two requirements are if the patient partner will have contact with children or vulnerable adults, then yes, they should complete a CRC. And if the patient partner is working regularly on site, they should complete a criminal record check as well. One thing that's also important to note for folks who've done patient-oriented research before or currently working with patient partners, a patient partner's role may evolve and change over time. And although they might not need a criminal record check when they're first onboarded, if their role shifts and they are planning to take on new work, the requirement for a criminal record check might need to be reevaluated. And ultimately, it's the principal investigator's responsibility for ensuring that the need for a criminal record check is reevaluated before any changes to their role or changes to engagement. Also, importantly, the study team should pay for the criminal record check and not the patient partner. And all discussions about criminal record checks should be conducted in a trauma-informed manner. And as part of the appendices, we do have a template script for having a discussion with a patient partner. Also, we wanted to just flag for everyone at the Lunch and Learn today that we've learned through this process that there are a number of things that do not get flagged on a criminal record check. So for example, like petty theft or crime. And also if something is flagged, it's not necessarily an exclusion from their role as a patient partner. We've learned that HR works really collaboratively with folks to ensure that they're able to overcome any challenges or barriers. And we've also been advised that some offenses can be eligible for pardon and that your HR team can support you through that process. Okay, so badge or on-site work requirements. So patient partners should get an ID badge, just like a member of the study team, if they are regularly working on site at Children's and Women's, or if they're regularly representing your study team and community. So think more of that community-based research where folks are out working predominantly in community, but saying, I'm a part of the WHRI, they should have an ID badge. Also for regular on-site work, and of course, where appropriate for age and literacy. So maybe if you have a patient partner who's 12 years old at Children's Hospital, this is not feasible, but where appropriate, there are Learning Hub courses that we're recommending that all patient partners take if they're regularly working on site. Okay, Research Ethics Board requirements. So this is new. Patient partners should be added to section 1.5A of all Research Ethics Boards applications that they're going to be supporting. So just know you're not in trouble if you currently are working with patient partners and they're not on your REB applications. There are lots of folks who will be in the same boat. You can go ahead and add them to your REB applications now. Also, just noting, depending on the role of the patient partner, it might be more appropriate for them to be listed in section 1.3A if they're more of a co-investigator, or in section 1.4A if they're more of in that peer research associate role and require the online access to the REB application. Also, as long as it's appropriate given the patient partner's age and literacy, again, we're recommending that all patient partners please complete the TCPS2 course. And this is a question on the REB application, right? Section 1.6, just confirming that all research personnel have completed TCPS2. So in the cases where it's not appropriate for patient partners to complete the TCPS2, again, like going back to a 12-year-old at Children's who might be a patient partner working with you, or someone with literacy concerns, it's ultimately the research team's responsibility to just ensure that the patient partner has had a chat and been familiarized with the TCPS2 and its principles. And then after this conversation, you can go ahead and select yes, even if they haven't completed it because of age or literacy or other related concerns. Guidelines for payment. So this is so important, and I think lots of folks working in this space know this already, but please pay patient partners for their work. Everyone else working in research is getting paid, and patient partners should be paid as well. It's important to discuss rates and processes of payment, ideally in your first conversation with patient partners, just so there are no surprises later. So discuss things like, are they going to be paid hourly, or are they going to be paid by a flat rate? Also have discussions around frequency. So for example, will they be paid bi-weekly, or will they be paid like half now, half at the end of the year? All of these specifics should be discussed upfront. A minimum rate of $25 per hour is recommended for all research patient partner engagement. This is based on already established guidance that the team has put together and collated. Also in our guidance document, we've linked a number of resources and recommendations for annual rates of engagement, if that's applicable to you or your team, or rates for elder engagement, which do vary. Also just highlighting that cash or e-transfer payments are recommended over other forms of payment. And I say like payment in quotation marks, you can't see me because my hands are down here, like a gift card, for example. So it's important to make compensation as barrier-free as possible. And waiting to receive a physical check in the mail from UBC or PHSA Finance is a barrier. So please just try your best. We have a bunch of guidance in the appendices to help guide you through that process. Also, just important to consider that other forms of payment, like gift cards, can be patronizing or stigmatizing to some folks. Importantly, as research staff, it's important that we are able to reconcile these payments with finance after the fact so we don't get in trouble. So if you're paying cash, you need a signed receipt from a patient partner. If you're paying e-transfer, a screenshot of the e-transfer is sufficient for reconciling. And we do have an example of what like a receipt would look like if you're having a patient partner sign a receipt for cash payment that would need to be submitted to finance. Also important to be prepared to have a discussion about the impacts on a patient partner's tax situation. So honoraria exceeding $500 per calendar year should be actually reported on your tax return. So it's line 10400, which I learned this year. Especially if patient partners are not being paid or in cash or e-transfer. This could impact, for example, some folks who are in social assistance. So it's just important to have these discussions up front. Also ensure that other expenses like parking or lunch or any other fees that a patient partner might incur as a result of being part of your study team are covered by the research team so that the patient partner is not out of pocket. So this was a question that our team got asked a lot. So because there's already a ton of guidance around like how much to pay patient partners and how to do it in an equitable, patient-centered, trauma-informed way, but how do we as research staff at BCCHR or WHRI actually physically get them the money? So we have step-by-step instructions for how to pay by cash or e-transfer on PHSA and cash or e-transfer with UBC accounts, where we walk you through with screenshots. We also have identified the BCCHR finance contact for you if you're struggling for how to pay patient partners or reconcile their payments. And then the counterpart at the WHRI. So it's Andy at BCCHR and it's Soraya at WHRI who can help you ensure that the payments are processed and reconciled appropriately. Moving on from onboarding requirements and recommendations and on to training and orientation. So patient partners should be trained and oriented to your project in a similar manner that you would train or orient a new staff member or volunteer or trainee at Children's and Women's. It's really helpful to identify a primary contact up front and schedule a one-to-one for the patient partner and the primary contact so they can run through any questions together. And this contact will remain their contact or should remain their contact throughout the duration of the project. So if they have any questions about like IT or payment, compensation, scheduling, they can liaise with this one individual rather than trying to find out in the team who's the best person to go to. We're also really recommending that you schedule an orientation with the wider research team for the patient partner to have an opportunity to meet everyone. And prior to this orientation, patient partners should receive an agenda. This is something that we've heard time and time again is really important so the patient partners know what they're walking into prior to this orientation meeting. We also recommend that at this initial orientation, you co-draft terms of reference or guidelines. And in the guidance document that we have that you see on the right-hand side here, we have a number of headings that we recommend that are covered as part of the terms of reference, including payment, how and when am I being paid, confidentiality, overall responsibilities of the patient partner, and a number of other things. We also recommend that for folks working specifically in pediatrics research, that the patient partners complete a course on the Porch website, which is linked in the guidance document. We also have another number of other considerations that didn't really fit nicely into any other section that we've included here that are important to highlight as well. So just noting, for example, communication preferences whether the patient partner prefers to be contacted via email or text or phone, and just ensuring that you've asked that question and you know the answer to that, so you can communicate with them in their preferred way. When you're scheduling meetings, it's important to take their schedule into account in the same way that you would take the principal investigator's schedule into account. So we've heard from patient partners that sometimes, there's lots of busy people and there's busy doctors and busy investigators. But sometimes when scheduling meetings, folks have felt like, oh, well, all the doctors are available at this time, but the patient partner wasn't, so we schedule it based on the doctors. And that's not good engagement. So just keep that in mind, that their schedule should be considered in the same way as you would consider the principal investigator schedule. Also, we recommend that you schedule regular meetings with your patient partner and avoid having contact solely over email. There are some things that everyone knows. It's easier to ask a question in person and not feel like you're bothering someone via needing to think about it and write it out in email and feeling like you haven't articulated it properly. So having some, whether they're Zoom meetings or face-to-face in-person meetings, but having that time to connect verbally. Another thing that I've learned that I think is so important is it's really important that the patient partner benefits from working on this project. So you should consider helping them with their resume and their CV and mentorship, and what are their career goals, and how is this position within the research study team helping them reach their goals. Can we get them access to the UBC library so they have access to journals that are typically behind a paywall and not open access? Can we write a reference letter for you? Something to ensure that they're getting benefit from being in this role, and it's a mutually beneficial relationship, basically. Also, after the project is done, it's important to continue to check in with your patient partner at least annually, just to reassess their interest and capacity in being involved in future research projects. At the end of the guidance document, we also have contacts. I feel like it's so important, especially in research. We can put out this guidance information, but sometimes there are nuances and you just need an ear or someone to bounce something off of. So if you have questions about patient partner engagement in a research context, we have a number of contacts for you here. One being the BC support unit. You can click that link and schedule a meeting with Larry at the BC support unit, a one-on-one. He's amazing and such a valuable resource. You can also reach out to myself on the BC Children's side of things, or Nicole at the BC Women's Hospital side of things, and also reach out to Mary McKillop at the Children's and Women's Patient Experience Office. So that is the guidance document. I'm now going to mute myself and turn things over to Henry. I also just wanted to briefly say that when Nicole, Linda, and I were sort of envisioning this work and this guidance document, we also had the vision of a sorting tool, similar to folks might be familiar with the PHSA, like REB or QI, QA sorting tool that helps research teams determine what onboarding or training requirements might be required of a patient partner at Children's and Women's. So Henry has made this dream come to fruition for us and is going to explain a little bit more about it. So turning things over to you, Henry.
Thank you very much, Shanlea. That was a beautiful presentation there. So hi, everyone. I'm going to be going over the patient partner onboarding requirement sorting tool today. And to begin, I would like to mention that this sorting tool does not replace the guidance document that Shanlea has just discussed with us today. But instead, this sorting tool has been designed to help study team members who have already reviewed this guidance document and who will be identifying tasks that their patient partners would need to complete. Some of you may recognize this tool, as Shanlea has said. This tool has been modeled after the PHSA project sorting tool. And so, yeah, now we're going to go into what we would expect when we go into the sorting tool. Next slide, please. So questions in this tool have been tailored to answer some broader recommendations like your patient partner, would they need an ID badge? Would they need to complete a criminal record check? Would they have certain courses to complete? So this guidance document that Shanlea has just shared with us today goes into greater detail on some of these things, but we would want to know if your patient partner would be working with children or vulnerable adults. Would they be working on site or remotely? And would they be supporting any pediatric research or supporting an REB approved study to help us identify some recommendations that would be suited for them? And depending on the answers you have to some of these questions, the recommendations that will be provided will be different. Next slide, please. So you expect to see recommendations like, discussing compensation with your patient partners. Would your patient partners need to complete a certain document and read and sign that? What are some tasks that the study staff would be needing to do, such as scheduling a one-on-one meeting with your patient partner for orientation, training, and even introducing them to the study team as well? Again, this guidance document goes into greater detail on how we should go about this and the processes to be able to accomplish this. Next slide, please. So now we have reviewed our recommendations page. We would need to submit our survey. This will give us an opportunity to be able to download a PDF copy of our responses. Next slide, please. And this PDF should be stored and referenced by study team members in the future. And this PDF copy should also be sent to your principal investigator. And after submission, you will also have the opportunity to open the guidance document as well as the appendices document, and they would be able to guide you to follow some of the Institute's approved processes to fulfill any recommendations that you would need to onboard your patient partners. Next slide, please. So now we're going to go try this document together, this sorting tool together. And there's currently a QR code on the screen. I have also sent out a link to the chat, which we can click on. And this will take us to the link to the sorting tool, where we'll try and work out an example scenario together. I'll just give folks a moment to click on that link. You can also use your cell phones for this QR code on your screens. Next slide, please. Okay, just as folks just get into that link we have in the chat, as we get into this link, I want to draw your attention to what our slides currently say. So now we have our example scenario here. Okay, so now I have a patient partner and I would like to onboard my patient partner to my study. My study would be supporting the eating disorder clinics at the BC Children's Hospital, and the study has been approved by the REB. I would also like my patient partner to support a researcher in community with co-facilitating interviews. I would also want my patient partner not work on site. So like I said, they will be facilitating interviews in the community. So they will not be working on site. However, I would like them to come on site to have a one-on-one meeting with me, and also for orientation and training, and for me to introduce them to my study team. What can I do? I actually don't know. Well, this is why this sorting tool has been created, which we'll go into right now. I'm just going to share my screen now so we can go into that. All right, so this is what our sorting tool would look like. And we have our first question here, which is asking, is our patient partner affiliated with research at any research team in children's and women's? Yes, because we will be working for the eating disorder clinic in BC Children's Hospital. And have I reviewed the patient partner onboarding documents? Yes, I have thoroughly reviewed that. However, if you haven't reviewed that, we would encourage folks to go back and review this document before proceeding with this sorting tool. Will my patient partner have any contact in person or remote with children or vulnerable adults? Yes, they will be working in community. Will my patient partner be working regularly on site at CNW? No. So they will not be working regularly on site because they will be in community who facilitates any interviews. Will my patient partner primarily be working primarily remotely? Yes. They will be working primarily remotely, like I said, because they will be in community. However, I will like them to come on site occasionally for on-site meetings or orientations, training, and meeting the study teams. Will my patient partner be interacting with the study participants in the community? Yes. Representing my research? Yes. Will my patient partner be supporting an REB-approved study? Yes, my study has been approved by the REB. And will my patient partner be supporting pediatric research? Yes, because we will be working out of BC Children's Hospital. So now we're going to go into this next page that will direct us on some of the recommendations and tasks that, depending on our answers, we've received from our sorting tool. So now we can see that our patient partner will need to have a one-on-one meeting with me. My patient partner would also need to be compensated. So,
sorry, Henry, I'm only seeing a part of your screen. All good now.
There we go. Yeah.
You're muted, sorry.
Sorry, we work in the same office. I have to try and mute myself. But now I see my patient partner will need to be compensated for their work on my research team. And a lot of the processes on how to do this have been stated up with screenshots on finance and how that would go about in the guidance document, which we will need to reference back to. I would also need my patient partner to complete a pledge of confidentiality. I actually don't know where to find this, but if I go into the patient partner onboarding, sorting onboarding guidance document, I can find that there in the appendixes section. Will my patient partner complete the CCPS2 course? Yes, I have a link on there. And I would also need to schedule some time for orientation with them. I can also see that my patient partner would need to complete a criminal record check. And there's been some resources on how that can be done here. And it's also important for us to consider that we are going about this in a trauma-informed way as discussed on the guidance document. And ways on how we can go about this has been stated out for us in our guidance document. I can see here that my patient partner will need an ID badge. So I will need to go to the BCCHR hub to get that sorted out for myself, or the PHSA platform to get that sorted out for myself, depending on where my research will be taken out of. I can see that my patient partner will be needed to be added to the REB, and depending on their role in my study, they would either be added to section 1.5A, 1.3, or 1.4A. And because my research is a pediatric research, my patient partner would also need to complete the HORCH training. Okay, so now that we have familiarized ourselves with the onboarding guidance document and the patient partner sorting tool, it is important to know that if we have any questions regarding how we can go about this and whatever we can't find on our guidance document, we have some contact details on here that we can reach out to at either the BCCHR or the WHRI Institute. I'm just going to stop sharing my screen here. And next slide, please. Awesome. Now I'm going to pass it on to Heather to discuss.
Hi, thank you very much for having me, and thank you for the wonderful presentation. So just to provide a contextual example on how some of this can work in practice. Next slide. We have at the Endometriosis Pelvic Pain Laboratory at BC Women's Hospital and University of British Columbia, we have a patient research advisory board, and we have project partners that work on specific projects. So the advisory board is really focused on strategic direction of the research program, grant writing, knowledge translation, and the patient partners all work on specific projects as well as co-investigators, consultants, and team members. But recognizing there's lots of different ways to do patient engagement, and there's lots of different ways to engage people. Some teams might have a board-like model set up for a specific research project because it's a bigger research project, or also because we want to include multiple patient partners as best practice rather than just one. So next slide. So here I've tried to make a bit of a diagram of how patients find us, how we find them, and what we do at our center. So we do recruit through various methods, including physician referral. We do have a KT newsletter that goes out regularly. Reach BC has been great. Social media. We also should add public events that we have, and we have a website as well. So there's lots of different ways that you can access patient partners and that they can find you and you can find them. But what's really important to highlight is we always conduct an interview with our prospective patient partners. And during this time, we discuss the opportunities that are available on our team. We discuss their patient story, which is really important. We discuss what it means to be a patient partner, because it's very new for the majority of people. The expectations, compensation, payment scheduling, and really determine together whether or not it would be a good fit to work together. And I'd say that about 50% of the time, it's a good fit. So there are times when it isn't a good fit, and that's okay. Sometimes there are other opportunities that you can direct people to that are more appropriate. Then we determine a pathway that they might take to provide them with an appropriate orientation. So we ensure that they meet the team, that they have access to essential documents. And for onboarding, we do a confidentiality agreement, have everybody complete the TCPS2, and obtain details for payment processing. So depending on your population, as Shanlea mentioned, you might need to support people in completing the TCPS2 because it is quite long. I'll note that this process is revisited regularly because our patient partners, as probably most people who have a research program will experience, often jump onto new projects and different projects. So you have to kind of go back to the beginning every time on every new project, and remember that you're building a relationship with people. So it's never too late to have these conversations if you've not had them already. And our process has definitely evolved over time, and we're going to be taking some of the guidance into consideration and implementing some more practices as we continue to learn how best to support our patient partners. So now I'm going to hand it over to Erin, who's one of our patient partners, to just talk a little bit about what it's like to be on the receiving end of all of this paperwork and discussions and, orientation.
Thanks, Heather.
Next slide.
Yeah. So hi, my name's Erin, and I'm a member of the Patient Advisory Research Board for the Pelvic Pain and Endometriosis Lab. Today, I'm just going to quickly go over 2 points that were important in my onboarding experience, as well as have been mentioned in today's presentation. The first being the trauma-based approach. I really cannot stress how important this is for building relationships and trust, which may have already been strained due to past experience. As patients, depending on our illnesses, it can take many years and many different medical appointments before we have a diagnosis, which brings me to my second point. It's best to lead with compassion and empathy to help create and nurture a safe space. Heather has created a safe space for our board because her empathy is not only just in her words, it's within her actions. So she'll provide advance notice for possible triggers in presentations, and she'll also make it very clear that if we're uncomfortable in anything that's said in the presentations or just in our own meetings, that she's there for us. The other thing that's really important, which was also mentioned in the presentation, is the professional development courses. Heather has sent us links for that. That shows us that she's not only thinking about us, but she's also invested in us. And as a patient, that's really invaluable. Which my last point for this is that patients feel like they're more in control of the diagnosis and health journey. So knowing that this safe space exists, it has enabled and motivated me more to take back control of my illness. It's tough with endometriosis, but through this board, I feel as though I'm helping and I'm doing more. And whether that be just in the month, like the bi-monthly meetings or a specific project, it helps. Even today, I'm not doing the best. I'll be honest, I've been up since 5. I'm in a solid pain 8, but I'm here because I know that it matters. And also because of the relationship that Heather has built with us. Okay, the other fun thing that I want to talk about is the TCSP2. So with that, this made me feel as though the position was more official and it highlighted the impact of the work. My background was in film. I don't know much about health grants. So to kind of go through the process to learn about the ethics, it really highlighted what we were going to be doing. And it's a good insight for people who don't have a familiar background. And then the other thing with it, as Heather was saying, it's quite large and it does take some time, but you are able to print off the pages. So that's really helpful for patients if they're unable to have access to a computer for a length of time, or for me, when I'm nauseous, looking at a screen is not ideal. So to be able to print it off, take my time, read it, and then be able to go back because they have that nice save and close, you can kind of go back and then go to it when you're able to at a better time. And that's about all I have to say for those 2 things right now.
Thanks, Erin. Do we have a next slide? Oh, thank you. So I'll pass it back to Shanlea. Yeah, that's all.
That's all we have. Thank you so much, everyone. If there are any questions, we're happy to address them in the chat or the Q&A these last few minutes before we break at 1 o'clock. And we also have all of our contact information if you have any questions about the guidance or how to operationalize it.
Thank you so much, everyone. Fantastic. I'm sure everyone is just in that patient partner sorting tool. Henry, I'm sure you can see like a ton of activity happening and everyone. There's one question from Katrina in the chat. I just wanted to flag. She said, we've been investigating. I think this goes back to the finance piece, Shanlea, and the taxes. We've been investigating whether it's possible to get a T4 issued for our patient partners. Have you been able to arrange this? I haven't. Has anyone on this call been able to do that?
I can speak to that a little bit. So I believe in the actual recommendations for the guidelines when you're filling out, when you're paying patient partners through UBC, they ask you to provide a SIN number and you can put 00000, but I've had finance come back to me and say, no, that's not allowed. So once you provide a SIN number, then you're able to get a T4 issued through UBC. I'm not sure how that works through PHSA though. Shanlea, have you had a different experience?
Katrina says they're paying their patient partner through PHSA. Katrina, we can help you with the Research Institute. We have fabulous finance people who can help sort that out for you. My experience with the patient partners that I've worked with is they specifically do not want a T4 for this for a number of reasons. So I haven't investigated that myself, but we'll help you navigate that. That's part of the great part about getting this group together and putting out this guidance is that there are lots of folks who have questions about how to do this, and we're here to help.
Thanks so much, Shanlea. I'm seeing lots of gratitude from Katrina. Yay, we'll be in touch. Bahi has a question. How do you define vulnerable adults? Are all patients vulnerable adults?
It's a good question, Bahi. So what we have recommended is because it depends on whether you're onboarding the patient partner through like UBC and paying them through UBC funding or through PHSA and paying them through PHSA funding. So we're recommending that if you have specific questions related to the criminal record check piece, that you reach out to your HR representative. You can also come speak to Nicole or I if you have specific questions about the nuances of whether or not a patient partner might be considered vulnerable as per the criminal record check requirements. But no, all adults are not considered vulnerable.
No.
Yeah.
No. And I think there's some patient partner groups that are also trying to kind of use language in an intentional way and in a patient-centered way of how we sort of make assumptions about vulnerability and what can sometimes be seen as paternalistic, even with our best of intentions. So, but thank you for that question. Any other questions, folks? This was fantastic. I'm sure I can't wait to tuck in and actually use it now that it's when it went live at what, like 9 o'clock this morning, Henry. So yeah. Okay, folks. Erin, thank you for joining us. Thank you for your honesty and just really incorporating the patient voice into what we're trying to do. That's we very much appreciate it.